Assalamu alaikum. Thank you very much, Mr. Chairman, for the introduction, and thank you very much for the very kind invitation. I would like to, first of all, thank and also at the same time congratulate the organizers for the wonderful conference. I would in particular like to thank Dr. Saad Al-Rashdi, Professor Pignol, and Dr. Nadeem for the very kind invitation, welcome, as well as the hospitality. The charge for me today is to talk to you about immunomodulation and immune checkpoint inhibitors. And at the outset, I would like to just say one thing. You would not see lots of survival curves over here because that part would be taken care of. The clinical trial and the results would be taken care of by my colleague and a very good friend, Dr. Faisal Azam, who is in the audience and who would talk to you in the afternoon. So we deliberately we spoke to each other to not to overlap. How does it work, Dr. Zahid? I'm starting around now, which is 10:45, and I know that we have to stop at 11 for the Friday prayer. So I would adjust my time accordingly.
So after this, we'll collect also for group photo, but I'll leave the timing to you.
Okay, thank you very much. So those are my disclosures. And what I would like to do is to get your opinion, first of all, about a few things that I would like to talk about. I wanted to do a poll, but I know that it is a bit difficult over here. But with the show of hands, may I ask you, how many of you would like to say, how many scientists received an award, a Nobel Prize on immunology in cancer work? And I will just say, if it is 11, 14, 19, 24, or 20, show of hands, you can tell me, and my chairman of the session would make a note of that. How many of you would say 11? That's quite a few. How many of you would say 14? That's a very few. How many of you would say 19? That's another very few. 24. 1 and 2 hands go up. 26. Another few hands go up. Thank you very much. There is 1 or 2 repetitions as well, but that's fine. I've got 2 more questions for you. Siplusil T is approved for use in the treatment of metastatic prostate cancer. Which class of immunotherapy is Siplusil T? Is it a cytokine, an immune checkpoint inhibitor, a CAR T cell, a vaccine, or a oncolytic therapy? 1. How many of you would say it's a cytokine? No. Immune checkpoint inhibitor? No. No. Is it a CAR T therapy? No. Is it a vaccine? A few hands go up in the air. Thank you. Is it an oncolytic virus therapy? Another few hands. So I think there is the house is divided between the answers. So it would help in the end to see whether I was able to explain what I was charged to explain to you. A LAG-3 inhibitor together with, and this is the last question, by the way, a LAG-3 inhibitor together with nivolumab has been approved for use in metastatic melanoma after demonstrating an improvement in progression-free survival. Which one of the following is a LAG-3 inhibitor? Is it dostarlimab? Yes or no? No. Is it durvalumab? 1. Is it semiplimab? No. Is it spartizulimab? Yes. And is it relatlimab? So a few hands. So once again, I think I've got a little bit of a task here to explain what is what and what are they doing. So what I would like to do in the first 7 or 8 minutes is to draw your attention to this very, very complex subject of immunomodulation. We often speak about immunomodulation, but it is really a very complex subject. And in doing so, while I do that, I will also talk to you about the potential areas for research. As my previous speaker, Dr. Saiful Haq, very rightly pointed out that there are lots of opportunities. And this morning I was speaking to Professor Anwar Hussain, who also said that there are lots of opportunities for research in the area. So I would like to highlight some of the things over there. In the next 5 or 6 minutes, I would like to talk to you about the different types of immunotherapy that are now in clinical practice, and finally about the immune checkpoint inhibitors. But I would like to confine my talk to basically the mechanistic side of immune checkpoint inhibitors and ask Dr. Faisal to talk about the clinical trial results later. That is the complex picture of immune system of the body. And you are aware that there are lots of, let me just bring the pointer here. There are obviously the innate immunity. There are so many types of cells. The natural killer cells is over there, although it's a lymphocyte, but it's in the part of the innate immunity. The macrophages, eosinophils, neutrophils, the NK T cells, and dendritic T cells, which also play a part in the adaptive immunity. And when you look at the adaptive immunity, it's mainly the lymphocytes, the B and the T lymphocytes. Some of them produce the B lymphocytes produce the antibodies. And the T lymphocytes, again, there are so many types: the Th1, the Th2, the Th17, and the T red cells. And I think we will talk more and more about the T red cells as we go along, because these are very important cells in immunomodulation, actually causing immunosuppression. And here is probably a pointer to what I said initially. In the last 1.25 centuries, 19 people have been awarded with a Nobel Prize for immunology and research. This is a slide which you have seen hundreds of times. This is the famous Hanrahan and Weinberg slide, which talks about the hallmarks of cancer. And I just wanted to draw your attention to this very important point over here, which is how the cancer avoids the immune recognition by the cell. And now we have got treatment for that. Not only that, but there are other treatments as well, which we shall talk about. Immune modulation is obviously a question, has been a topic of the whole discussion for the last century or so. Why is it that tumor, which is a foreign cell, is not recognized by the immune cells as a foreign cell and is not rejected? The reason for that is that the tumor and the immune system, they live in harmony and they shake hands with each other. It's important to recognize those shaking of hands and to break those bonds to be able to let the immune system overcome the tumor. Obviously, there are various targets, and over the next few slides, we will talk about those. You can go right in the bullseye and try and change the cells, the cytokines produced by the cells, or the antibodies produced by the B lymphocytes, and make a change over there so that they can recognize the tumor cells as different. Or you can change the tumor microenvironment. And we can talk about tumor microenvironment for a whole lecture as well. But this is so very important as to why whatever you see within the slide, there are very few tumor cells, and the rest of the cells are very different. Those could be modulated as well to treat the cancer. And then there are extrinsic factors, what we eat, how we eat, so on and so forth. Those could also modulate the immune system. Now, here are two slides which are opposite to each other. First of all, the tumor cell which sits in the center over here, there are lots of cells, the antigen-presenting dendritic cells, the mast cells, the natural killer cells, the macrophages, the neutrophils, the T lymphocytes, the B lymphocytes. They produce various cytokines and factors and substances in order to eliminate the tumor cell, but usually they would be not successful. And why are they not successful? Because tumor has got mechanisms to evade that. For example, the production of M2 type of macrophages. And we will come back to that as to what type of M1 macrophages and how does it differentiate from M2 macrophage. Abnormal antigen presentation by the dendritic cell, the negative stimulatory cells such as the Treg cells, which are the counter-regulatory or cause immunosuppression, the low immunity of the tumor-associated antigen, the T lymphocytes, could be all blown away, and they could be exhausted. The induction of Treg cells, and so on and so forth. Now, I would like to come back to the mesenchymal stem cell in a minute after I speak to you about the tumor-associated macrophages. Macrophages, as you know, are derived from the monocytes. Now, the monocytes, when they come, whether they come from the blood here in the green or from the yolk sac, when they enter, when they come in, they are acted upon by either the tumor cells through the various cytokines, like, for example, over here, including interleukin-10, or the tumor microenvironment, which includes Treg cells, which also interact through the interleukin-10, or by various other cytokines directly on the tumor-associated macrophages. And then we have got the tumor site, which also produces its effect on the macrophages, and then the hypoxia-induced factor, the HIF, etc., so on and so forth, the mesenchymal stem cells, they all act upon the tumor-associated macrophages to let them differentiate into two types. Usually, it's the type 1 macrophage, which is good for us, which causes immunity, which is the antigen-presenting cell. But these factors, these 4 different factors shown in the cartoon over here, they transform the macrophages to the other form of macrophage, which is the M2 type, which actually promotes, which actually is anti-immunity, and that it helps, the tumor is promoted because of that. And you can see the M2 type of tumor-associated macrophage over here, causing cellular initiation through various cytokines, including the IL-17 and the IL-26 over here. It causes immunosuppression through the cytotoxic T lymphocytes and the Treg cells. It causes metastasis and premalignant niche because of the secretion of lots of factors, including the extracellular matrix degradation. And finally, it causes angiogenesis and promotes angiogenesis, which, as you know, is an important factor in the tumor progression, and that is because of the hypoxia-induced growth factors and release of lots of other cytokines. So these macrophages, if they transform into M2 types, they actually cause tumor progression instead of acting as immune cells. You can take advantage of these tumor-associated macrophages and use them for different in clinical practice. They can be used as biomarkers for diagnosis of cancer. They can be used for to prognosticate the tumors. And more recently, people are looking into the therapeutic target. For example, by limiting the recruitment of monocytes into macrophages, or by targeting the activation of the macrophages, or by reprogramming the tumor-associated macrophages from M2 back to M1, etc., so on and so forth. I think the last thing that I want to talk to you about in the immunomodulation is this issue of the gut microbiota. And I think this is one of the major areas of research. Lots of people today would be doing research on that, and that is something which is very relevant and pertinent to our area. What we eat in the Middle East, what we eat in Pakistan is very different from what is eaten elsewhere. Chances are that our gut microbiota are very different from the gut microbiota of other countries. And here, what you see is that the gut microbiota, particularly the Bacteroides and a few other species of bacteria over here, they act on the dendritic cells, and they produce effect on the macrophages and the release of cytokines. And these cells then live in a state of harmony. When we take antibiotics, obviously these microbiota are disturbed. And there has been a lot of talk in the last 3 or 4 years that people who are taking immune checkpoint inhibitors or are treated with immune checkpoint inhibitors, if they were at the same time given antibiotics, maybe the efficacy of ICIs would be reduced. And the reason for that is because of the way that antigen dendritic cells process the function of immunity over here, that might be altered. So the question then is, in clinical trials, can you restore the microbiota back to normal? And there are lots of studies on that. For example, the fecal transplants, for example, the use of bacteria being fed on the spoons, so on and so forth, the probiotics, and whether or not they would change the immune checkpoint blockade and lead to tumor cell inhibition over here. I've got 15 more minutes, so I hope I will be able to finish in time. I change gear now from immunomodulation, and I move on to the types of immunotherapy. Now, what you see on this slide is that there are different types of immunotherapy. Here in the green are the non-specific types. Most of us have used these already. I've just now introduced to you the microenvironment modulators, which is modulating the tumor-associated macrophages and the intestinal microbiota. And then the tumor agnostic, for example, the immune checkpoint inhibitors, the oncolytic virus therapy, the CAR T-cell therapy, and the cancer vaccines. And this is a cartoon which shows that all of those can act together or in various proportions against the tumor cells. I begin by using cancer vaccine. Vaccines have probably, as you know, changed the outlook of healthcare throughout the world by prevention of cancers. But the concept of therapeutic vaccines, once the cancer develops and when you use vaccines to treat the cancer, that has been, people have been playing with that idea for a long period of time, but not very, very successful. And there are obviously lots of reasons. One of the reasons is that as soon as the vaccine came up, there was something else which came up at the same time. For example, in case of prostate cancer, when Ciprucil T was approved for use as a vaccine against prostate cancer, at the same time, enzalutamide capsules were also approved for use. And obviously, people went for the easier treatment, which was enzalutamide, and Ciprucil GP100 for melanoma was another vaccine, a therapeutic vaccine, did not work because at the same time, ipilimumab came along as well, and that changed the whole thing. All I want to show you over here is that there are lots of trials in phase 1, 2, 3, and even phase 4. Dr. Zahid told you about that. I work, I do women's health, gynecological cancers, and I know that there are trials now using the vaccine for against the E6 and E7 epitope of the human papilloma virus, which are being used for treatment of cancer of the vulva, for example. And then we have got the oncolytic virus therapy, where you introduce a cytotoxic virus into the tumor cell, let the tumor cell then replicate and produce antigens which would cause a local immune reaction and then go on to treat the cancer locally. It is injected intralesionally, and one of those, which is approved for use, is already there in melanoma together with ipilimumab, and that is being used. I don't know if people have used that. I am certainly not treating melanoma now, so I do not use this. Cytokines, we have all used. Professor Anwar Hussain would tell you all about cytokines, how long they have been used for the treatment of, particularly for renal cell carcinoma and etc., so on and so forth. There are different pathways. Most of them relate to the interleukin-2 and interferon alpha for melanoma and renal cell carcinoma. Not easy drugs to use, associated with lots of side effects, but nevertheless, they are still there and being used, sometimes in combination with other drugs. And then we have got this adaptive T-cell therapy. The concept is very simple. You take the T lymphocytes out, you send them to a facility which would make them into several lymphocytes, very active lymphocytes, and you reinfuse them back. And the T lymphocytes would take care of the tumor, but you need to have a proper antigen sitting on the cell surface so that these T lymphocytes, when they come, they bind to the right epitopes on the cell surface. And at the moment, there are at least 6 different CAR T cells, the chimeric antigen receptor T cells, which are approved for use mainly in multiple myeloma, follicular lymphoma, diffuse large B-cell lymphoma, and acute lymphoblastic leukemia as well. Very few in the solid tumor, but that is again a very active area of research. Can you identify antigens on solid tumors in the areas that you work in, which would not be internalized, which would not be disintegrated, but which would sit on the cell surface, be recognized by the T lymphocytes, and then you let the T lymphocyte do the rest of the job. So that is some of those are in practice. For example, the MUC16 antigen. We, in the center where I work, we have developed a research proposal for that, is to look into management of use of CAR T cell for the ovarian cancer, because ovarian cancer express MUC16. And obviously that the most important thing which most of us know is the immune checkpoint inhibitors, where different types of cells like the dendritic cell, which are the antigen presenting cell, the T lymphocytes and the macrophages, they all shake hands, and also shake hands with the tumor as well by the way of these very strong bonds, and then do not let the tumor be seen as a foreign self, because they all are live in harmony. And in 2018, as you can see over here, a Nobel Prize was awarded for the use of immune checkpoint inhibitors, for the advent of the discovery of the immune checkpoint inhibitors. I think, and I think many of you think as well now, that immune checkpoint inhibitors is one of those quantum leaps in the history of management of cancer, going back to the surgery 125 years back, the radiation fractionation over here, the advent of the chemotherapy during Second World War, the use of antibiotic, the observation by Gerald Bode and colleagues, the magic bullet in 1999 when imatinib came for treatment of acute for chronic myeloid leukemia, and now the immune checkpoint inhibitors in the last decade, they have really changed the game. It's a sort of a game changer. Before coming over here, I just had a chance to do a very quick bibliometric analysis on single checkpoint inhibitor. If you go on a Scopus database and just type in immune checkpoint inhibitor, what you see is that before 2015, there were only 70 publications in 2017. Every year, and last year, there were 3,000 publications. And the publications are in 2023, only till July, there are already 2,500 publications in indexed journals. That is how much people are talking about the immune checkpoint inhibitors. And if you want to know who's doing that, then obviously the two major players here are the United States and the China, but also Japan and Italy and France are not far behind as well. And if you want to look further as to who is producing it, which journals are publishing it, and which authors, I don't know if it projects all that well on the screen. I'm sorry for that, but I just want authors are from China. And here are the countries of publication. The two countries which are publishing the most are United States and China, and then there are other countries, and those are the journals, but we will talk about it later as well. So very quickly to the third part of my talk now, which is the mechanism of action of immune checkpoint inhibitors and the mechanism of resistance, which is what we see over here. The antigen presenting cells, they come in contact with the T cell to prime them, but because of the very important and very vivid bonds over here, for example, the CTLA4 and the CD28, etc., the T lymphocytes do not get activated, and they do not do anything to the cancer cell, which in turn are bound to the T lymphocytes with these receptors over here. But the moment you use the monoclonal antibody, the cytotoxic T lymphocyte A4 antibody, we call ipilimumab now, then ipilimumab would displace the CTLA4 from here. The CD28, which is a co-stimulatory molecule, binds to CD28, and the CTLA4 then would allow the T lymphocytes to be activated after the antigen presenting cells present there, and then it would also cause obviously a cytotoxic effect here on the cancer cell. But now we also have the PD-L1 and the PD receptors sitting on the T cell and the cancer cells, and blocking those using monoclonal antibodies would further lead to activation of the T lymphocyte, and that would cause cytotoxicity. How do we choose? We all know how do we choose. For certain cancers, we do not want to choose. For example, for melanoma, for renal cell carcinoma, and a few other cancers, all comers, they get immune checkpoint inhibitors. In other cancers, and I'm not going to go into details because that is beyond the scope of this talk, you look at the tumor mutational burden. And how is it, 5 minutes? Yes, okay, thank you. Here in tumor mutational burden, some tumors have got very high tumor mutational burden. For example, melanoma, for example, renal cell carcinoma, cancer of cervix, so on and so forth. And immune checkpoint inhibitors are more likely to work over here if the mutational burden is more than 16 megabase over here. In some other cancers, obviously it is the PD-L1 expression on the cell surface shown over here in this part, and in yet other cancers where basically any tumor which shows a deficiency of the mismatched repair proteins, either in any one of those 4 genes, would be candidates for immune checkpoint inhibitors. So we are using all of those. You can see that for two of those ways of selecting, that is immunohistochemistry, but here you need next generation sequencing. And that is where the importance of the NGS on site comes into play, because then you want to do that test very quickly and be able to find out whether this patient would be a candidate or not. Immune checkpoint inhibitors are being used in all different sorts of settings, either a single agent in combination or in combination with a tyrosine kinase inhibitor, with radiation or with other agents. In the interest of time, what I will do is, I will, okay, first of all, let me just remind you of the sort of a paradigm shift in medical oncology. Last year, this was presented in ASCO. Patients who had mismatched repair deficient tumors, they were treated with dostarlimab. And the question was, the patients with rectal cancer were treated with dostarlimab. And the question was, could you obviate the need for surgery and radiotherapy? And the answer was, all 12 patients who were treated, who had mismatched repair deficient, treated with dostarlimab, after 1 year, they did not have cancer. They were living free of cancer without the need for surgery or radiotherapy, Dr. Zahid, as well. And that is how medical oncology is encroaching on to radiotherapy these days. I think in the interest of time, I'll have to skip this particular slide. Overcoming resistance to immune checkpoint inhibitors, obviously by combining them with either other immune checkpoint inhibitors, tyrosine kinase inhibitors, radiation, or with some other agents, very quickly. Combination here with another immune checkpoint inhibitor, ipilimumab, together with nivolumab, is better than either nivolumab or ipilimumab in melanoma. So that is first thing that we learned. The combination of another immune checkpoint inhibitor called LAG-3, if you use it together with the PD-1 inhibitors, then very recently you saw that there was an improvement in survival in patients with melanoma, at least in progression-free survival, patients who were treated with the anti-LAG-3 antibody. And here they were treated with this drug called relatlimab. So relatlimab plus combination with nivolumab produced that. And this is what was presented in ESMO this year, only a couple of weeks back. Addition of pembrolizumab to chemoradiation led to an improvement in progression-free survival. And you can see a 10% difference in progression-free survival at about 2 years when you add pembrolizumab to the standard of care chemoradiation, which has been the standard for the last 20 years or so. Skip that, and ask you questions once again. So how many scientists have been given a prize on immunology-related research? Who would go with number 3 as the option? Everybody. So I think this was clear over there. Siplusil is used for metastatic prostate cancer. What type of drug is it? Is it a vaccine? Yes, thank you very much. LAG-3 inhibitor is used together with nivolumab in metastatic melanoma. Which LAG-3 inhibitor is used? Is it the spartazumab or relatlimab? Relatlimab? Yes, thank you very much. With that, I thank you very much. Assalamu alaikum.